And it really is very much a therapeutic orientation that is centered on the concept that a person's thoughts impact how they feel.
You're listening to In Your Pants with Dr. Susie G, the physiotherapist for your private, helping you get in the know down.
Hey friends, it's Dr. Susie G here, and welcome to another In Your Pants podcast. So glad that you can join us today. In today's episode, I have guest Dr. Elise Bedell. She is a GI health psychologist and an assistant professor at the University of Chicago. She received her PhD in clinical psychology from Northwestern University Feinberg School of Medicine, where she pursued a research and clinical specialization in psychogastroenterology. I had no idea that this specialty in psychology even existed until I was blessed to meet Dr. Elise in our University of Michigan sexual health program. And I was so fascinated with not only her energy and passion for her work, but also just the whole field of psychogastroenterology. And I wanted to learn more. And so here we are discussing the ins and outs of what psychogastroenterology is and why someone would see a psychologist for GI-specific medical disorders. We chat about some of the common signs and symptoms and diagnoses that Dr. Elise sees in her office. Some of those are irritable bowel syndrome, chronic constipation, pelvic pain, inflammatory bowel disease like Crohn's. And then we also talk about the experiences that are common among people with chronic GI issues. So we chat about mental health concerns, sexual dysfunction, chronic pain issues, disordered eating, and also other life events that might contribute to the experiences in addition to GI issues. And then we chat a lot about the components of holistic and integrative treatment. You know, what does it look like to have a team, a wellness team to help support some of the difficulties and challenges that encompass, you know, chronic illness such as GI issues and pain. And then Dr. Elise takes us through her evaluation and what a typical treatment session would look like for her and her client. So this is a wonderful episode. You don't want to miss this. And she also provides a really wonderful resource that I'm going to link in the show notes as well for just a starting point to see if this could be something that is helpful in your life and to help with your concerns. So without further ado, I welcome Dr. Elise Bedell. Enjoy. Hi, Elise. Thank you so much for being on the show with me.
Thank you so much for having me.
And to all the listeners and viewers, I just want to introduce Elise. Not introduced, but I met Elise at the sexual health certificate program at the University of Michigan. And I found out that Elise has a very unique specialty. She is a GI health psychologist. And I was like, yes, we need to have you on the show because I had no idea this specialty existed. And it is from what I can gather and what you've described to me off the air, it's such an important need in medical care. So let's just dive into it as far as what is this mysterious field of psychogastroenterology?
Yeah, well, you pronounced it right. So kudos to you. Already off to a great start.
I've been practicing.
So psychogastroenterology is a field that really references both the research and clinical space that is the intersection of psychology and gastroenterology. So gastroenterology being all the stuff related to your digestion. And so, as I guess a little bit of background, some folks may know there is a really strong relationship between your brain and your GI tract. And so I think even over and above some of the other relationships between the brain and other body systems, there is just a really huge component of what's going on in your brain and how that impacts your gut, and then definitely vice versa as well. So again, like folks might know that there are psychologists that work in all kinds of medical specialties. So, sometimes they are in urology, sometimes they're in gynecology or oncology, all these different things. And so in gastroenterology, psychologists in the last, like really the last kind of 10 to 15 years, it's really taken off. So it's kind of a small but growing specialty, psychogastroenterology.
Say that 10 times fast. I'm interested. I'm interested in what inspired you to get into this specific field of
Yeah.
psychogastroenterology.
Yeah, well, I had an experience as a teen where I have a family member that's very close to me that was diagnosed with Crohn's disease. And so watching that family member's experience in the medical field and, in many ways, got really great treatment, but it was very clear to me that there was kind of a component of that was just missing. And also very clear to me that that there's just a lot of stigma and can be a lot of embarrassment associated with GI issues. And so it wasn't actually until later I have a sister that became a gastroenterologist. Interestingly, I knew that I wanted to become a psychologist, but I wasn't exactly sure what type of specialty I would have. And for folks going into PhD clinical psychology programs, you really do have to kind of decide on a research focus before you're even applying. And I discovered Dr. Lori Kiefer's psychogastroenterology program at Northwestern. And that was like, whoa, it was a specialty I didn't know existed. And when I saw it, it was like, that's where I need to go. And I was lucky enough that I was able to get into my dream program. And so that's where that went.
Oh, well, that's amazing. We're so glad that you're doing the work that you do because there are a lot of common diagnoses and symptoms that you work with. Could you explain to us those diagnoses and symptoms and how your work is integrated into that?
Yeah, absolutely. So as a GI psychologist, we really are trained to work with any type of gastrointestinal disorder, and the work might vary somewhat disorder to disorder, but a lot of it actually can be pretty similar. It's grounded in a lot of times the cognitive behavioral theory, definitely the biopsychosocial model, which I'm sure that your listeners and viewers have heard about in the past. And so, some of the most common conditions that I treat are irritable bowel syndrome, for short IBS, for people. That's oftentimes a disorder that we hear a lot about, but many times people don't know exactly what it refers to. It's an abdominal pain syndrome with associated abnormalities in the consistency, frequency of the stool. And then I work with a lot of folks who have inflammatory bowel diseases like ulcerative colitis or Crohn's disease, patients with different esophageal disorders, could be difficulty swallowing, could be disorders where there's inflammation that requires different types of treatments of the esophagus. So it really does run the gamut. I also work with patients who have fears around eating, could be due to a diagnosis like celiac, for example. So really kind of anywhere you can imagine your GI tract, which is really your mouth all the way to your anus, it can work really well, or there can be problems. And if there are problems, then a GI psychologist can work with those conditions.
That is amazing. So everyone knows that I'm a pelvic health therapist, and we both are now, in the realm of sexual health counseling and education. And chronic pain, pelvic pain, and GI issues, I feel like go hang together because they're so close in proximity to one another as far as the nervous system involvement, and even just from a mechanical standpoint of like neuromuscular motor control and coordination, as far as just being able to perform functionally those muscles to be able to poop. And so I'm curious as to your experience with if you've had experience working with other pelvic therapists, and how do you all collaborate together as far as a team in helping someone who has like pelvic pain in addition to GI related issues and symptoms?
So I consider pelvic floor physical therapist kind of like a major cornerstone of a lot of my patients' treatment. And so, oftentimes my work with my patients can be, I consider it a little bit of kind of a consultant, where I know that I'm not the person to treat every aspect of their presenting problem, right? There's biological components, which could include, and at least in my mind, I can kind of consider some of the muscular components kind of to fall into that category. There could be dietary components. There can be definitely medications required. There can be psychosocial factors. Some of those, when they're really psychosocial or what we sometimes call cognitive and affective factors, those are the things that are definitely in my wheelhouse. But sometimes it just takes being able to have an hour-long conversation and to have a couple of hour-long conversations with someone that really knows this stuff to also be able to identify what are some of the other factors that haven't been seen. So sometimes I am the first person to pick up on the fact that this person has not had a pelvic floor evaluation. And if certainly someone's referred to me that has chronic constipation or pelvic pain or oftentimes both, that's going to be a recommendation I'm going to make to their gastroenterologist is that, yeah, I'm happy to work with this patient, but we really also need to make sure that they are getting worked up and treated for any kind of muscular components to this. So then it does definitely become more of a co-treatment where I'm working more on the psychosocial aspects, and then the physical therapist is working on sometimes also addressing some of those. Actually, some of the really great ones that we know are talking about it as well. But definitely working at it kind of from the way I think about it is the more muscular or physical kind of perspective. So as you said, definitely these things hang together. My GI patients, when I ask them about their sexual functioning and about other types of pain in those areas, are sometimes a little surprised by that. And I kind of have to explain that these muscles are not in isolation. And as I've heard you say before too, men also help pelvic floors. And it sometimes even are like even the most fantastic medical providers sometimes can forget that as well.
Yes, this is true. Not to put, not to call anyone out, but this is true.
Yeah. There's just a connotation that we have about pelvic, right? It just seems kind of like it relates to women. And so some of that's education I can help with as well. But just to kind of circle back a little bit about our, mutual, our connection and the sexual health work that we're doing, it was actually, I did a rotation during my clinical psychology internship year that was in oncology and doing a sexual health, sex therapy focused training there. And that's when, I had no experience in sex therapy and in that field before. And it was really having, 6 months of working in that I was just like, our GI patients need this.
Yes.
Like this stuff hangs together. And I realized that, partly I didn't know how big the scope of the problem was because these were questions I wasn't asking, right? I think there's oftentimes this fear among any type of provider, including mental health providers, that if we ask about it, we might need to be able to do something about it. And so that kind of, I sort of felt like that was my calling. Like, I think there's a lot of stigma and misinformation in GI. There's a lot of stigma and misinformation in sexual health. And, I kind of want to be part of that solution.
Well, again, we thank you for doing the work that you do because it's so important. Speaking of stigmas, so there's two things rolling around my head right now. One, what are those stigmas related to GI? And second, the stigmas around just mental health and psychology, because I feel like, and I could be completely wrong, but for the patient population that I work with, bringing up even just bringing up saying, hey, maybe we should have another person on our team to help with the psychosocial aspects or your mental health and well-being. How do you navigate the buy-in, right? Because then you don't really want to say, well, it's all in your head, because that's typically the patient population that I work with, men who have chronic pelvic pain syndrome. They've been told that many times. So there's this huge mistrust in the medical community. And so I feel like there has to be a bit of a skill to kind of start to have this conversation and to perhaps zoom out. And as you've already mentioned, at least okay, here's the physical aspects that we're dealing with in this realm. And then we've got, what else is going on? Like, what is going on with your mood and your thoughts and your relationships and, your belief systems? Like, how is that all playing into, the mix? So I'm curious to kind of chat with you about your experience.
It is sometimes so messy, even in the best cases. It's like these concepts are tricky, because I think on one hand, like, I do very much focus on the fact that I treat medical disorders from a psychological perspective. And I think that that's really important for many of the people that I'd be working with because of that, whether they actually have experienced someone saying to them, this is in your head, which in some cases I believe them that they have. But what's more common is just, I think, oftentimes well-intentioned folks in medicine or in other fields, or even among their own friends and family, that are actually trying to acknowledge the psychosocial aspects of pain and of chronic illness, but just maybe are missing a little bit of that nuance there, right? And it can come across as very invalidating. So I think for that buy-in piece, I do think it's really important. And so it's oftentimes a way that I introduce the work I do is that I am a psychologist, but I work with patients primarily on their medical disorder. And so to just kind of get on the same page that, no, I'm not actually here to treat you for depression or anxiety, though that might be something that's going on, not in every case, but sometimes it is. But really, in the scope of our work, I am here to really treat you for the medical disorder using things that we know from psychology can impact the way that our medical disorder actually presents. The other piece of that, and where I kind of say that it gets messy, is because I also want to be careful then to not stigmatize people who are experiencing depression, anxiety, or other mental health conditions, right? So it's not that we want to say that there's a dichotomy that one is better than the other, but I think sometimes just clarifying and giving each of these things their own space and respect. And similarly, I'm very, happy and can train, certainly trained to work with some depression and anxiety, particularly as it relates to a GI disorder. But there are also psychologists and other mental health professionals who are very highly skilled in working with patients who have depression and anxiety. And so sometimes that's also about understanding my skill set and being able to really work with a patient to determine if the scope of any mental health symptoms that are present are really best addressed in this type of a model, this kind of health psychology model, or really whether we think they're better addressed either concurrently with a mental health treatment or that they'd really benefit from a mental health treatment first. And then they may be in a position that they're going to be a little bit in a better place to respond to this more health psychology approach. So it is messy. Like I said, you kind of want to be able to hold both of these things. And certainly there's I think a lot of it just comes down to stigma about mental health, right? But then I think we want to sort of be respectful that sometimes people who have these physical conditions have been really invalidated. And there is actually, in most cases, a lot more physiologically that's going on than sometimes their test shows or their, providers even can kind of communicate. So that's kind of where my head is on that.
Yeah, no, absolutely. I totally hear you. And how would someone know then, like, I guess, how would someone discern whether they should see a GI psychologist versus another provider, like you're saying, another mental health provider who might be more skilled at anxiety or working with depression or some other mental health concern?
Yeah, I think maybe the easiest answer is in some cases, like, just go and meet with a provider and kind of tell them and help them guide your decision. As I oftentimes, I mean, I meet with a patient, have an evaluation, we can have a very clear discussion on what it seems like could be a good fit, because it's usually not one or the other, right? Oftentimes I might be able to meet with a person for an evaluation and we see like, you know what, we really would benefit from you being in a more weekly therapy with someone who specializes in depression. But I think there's actually something that we could do within even 3 sessions together to get you kind of on the right path with your physical symptoms. As you do that work, then maybe let's stay in touch and you come back to me once the depression is better under control, right? So there can be, oftentimes there is a more tailored approach to it that really depends patient to patient. But I would say if a person does feel like they have, pretty good insight into what's going on, then my metric would be if, a lot of the distress that you're experiencing on a daily basis is about your symptoms, your physical symptoms, and that's where a lot of your, like, the healthcare, your time in healthcare is being spent, and your stress and anxiety is less about other things going on in your life and it's really more centered on your physical illness, then seeing a psychologist like myself, if the issue is in GI, if you have access to a GI psychologist, great. If the issue is in pain and you have access to a pain psychologist, great. And if the issues are more about what we would consider to be a more kind of clinical depression or anxiety, and it's maybe grounded in other types of things going on in your life, that might be better suited to at least start that conversation with a general mental health provider, like someone that specializes in depression or anxiety. Then there's the piece too about access, and I'll just put that out there, right?
Yes. Mm-hmm.
Not everybody lives in kind of these major metropolitan areas that have access to all of these different providers. And so I would also consider, I think talk to your medical team. They may have some referrals. They may have some ideas already of therapists that have some training in this type of work. But if that might be a no-go as well. They might not have any better ideas. What I would say is to look for in a therapist is someone who has some training in cognitive behavioral therapy is usually a good sign. Someone that lists that they have experience working with patients with chronic health conditions. Also another good sign. And very likely, even if you're not working with someone that's highly specialized, that in a particular area, you will oftentimes have very, very good mental health providers that if they have some experience in working with patients with medical conditions, they can consult, they can get up on their reading, right? And so there are all kinds of ways that we kind of can fill in the gaps. But of course, my inclination is just that we need to get more people trained. We need to get more providers, right?
That's right. It's like sexual health, right? It's like we need everyone talking about it way more and having some accurate sexual health literacy out there.
Yes. Yes.
100%. 100%. So so can you walk us through kind of what a typical session would look like for you? So like say, for example, someone has, pelvic pain and constipation, perhaps IBS, irritable bowel syndrome, which is not uncommon. And I know in the research, there's a lot of correlations, right? IBS correlations with pelvic pain and vice versa. So what would a typical session look like? I mean, what kind of strategies would you two be working on? And yeah, just take us into your office.
Yeah. So the first thing we do, like I said, is to have an evaluation, and that's going to be a very jam-packed hour where we are going to get a lot of information about the physical symptoms. We're going to talk about things that maybe a person has noticed that worsen their symptoms, things that they've noticed seem to make it better, whether they have or haven't noticed a connection between stress and their symptoms. We're going to get a little bit of an overview of what types of medical treatments they've tried, what workup they've had. So there's going to be a lot of conversation that's really catching up on their actual physical symptoms. But we also are going to have to get a snapshot of lots of other areas. So expect to talk about any mental health history, kind of like how your mood is, what's your stress level like lately. We'll talk about social, just get a sense of the person, right? Get an understanding of what kind of social support they have in their life. So there's going to be a snapshot of a lot of different areas in that first evaluation, which will help someone like myself make a decision about treatment recommendations and some preliminary ideas of where we could go from there. Follow-up sessions, at least I can speak to my approach, are very highly individualized. So while I do see pretty much all the work that I do from a cognitive behavioral model, that's just my training background. I think there's kind of a misconception that can be kind of a cookie cutter approach for folks that maybe are familiar with the idea of CBT. And it really is very much a therapeutic orientation that is centered on the concept that a person's thoughts impact how they feel, and how they feel can impact all kinds of other things in their lives. But we can't really change feelings, right? We don't have a magic wand to like wave away feeling sad. But we actually can, with effort, make changes to our thoughts, which can then indirectly change our emotional state. Importantly to then the work that I do on both physical symptoms and on the GI tract in particular is that emotions are really key to whether your sympathetic nervous system or your parasympathetic nervous system is engaged, right? And so if we can change our thoughts, then we can help patients to get out of that that sympathetic arousal state,
Yeah.
which we know worsens all kinds of GI or all kinds of physical symptoms, including the GI tract, which is
Yes.
intended to change in its functioning when it's in a state of fight, flight, or freeze, right?
Right. Right.
So that's a pathway that we can use is actually working on the cognitive work, right? Behaviorally, sometimes that is just looking at how is a person coping. I
Mm.
work with some folks that are really great problem solvers, and that might serve them really well in many areas of their life. But when it comes to having physical symptoms that do not have an easy solution, they can kind of come up against a wall over and
That's
over and over,
distressing.
right?
I see that a lot as well. Yeah.
Absolutely.
Mhm.
So that's where we work on a concept called adaptive coping, and
Mhm.
that's really the idea that some types of problems are really best suited for these very action oriented coping strategies, things like making a to-do list, Googling things, making a list, right? Like problem solving. And if a problem has a solution, definitely use those strategies. But a lot of times when it comes to chronic pain conditions, when that there is not an easy solution, right? It's at least certainly not a short-term one. And so when we try to use those same very action-oriented or problem-focused, turning your attention toward the problem, we're kind of hitting a wall, right? And so it's in situations like that where folks actually need to kind of work on using these more passive coping strategies, things like distraction, things like actually turning your attention away, taking away a little bit of power from the chronic pain, let's say.
Mhm.
Um, those are things that, some people are over reliant on the passive and they're underutilizing some of the action that they can take, and some folks are kind of in the opposite scenario. So again, that's where it's kind of individualized, is where we look at what behaviors can we really optimize here. One piece that I want to highlight for people is to just give a little bit of clarity too on when I'm talking about things in our thoughts or psychological constructs that we might work on. And I talk about it not being just about depression and anxiety, because that's a lot of times what we think about, right? When we think about
Mhm.
psychological factors or mental health issues. But there are all kinds of things that are not depression and anxiety that can still be a little bit tricky and a little bit unhelpful. So two of the most common, or I'll say three of the most common things that I work on are GI specific anxiety. So anxiety, but
Mm.
not anxiety about other stuff going on in your life,
Mhm.
anxiety about the symptoms themselves,
Right.
right? So you may say like, well, I don't have a lot of stress in my life, so I don't think that stress is playing in a role. Well, actually, like, your symptoms are a source of stress, right? They're a source of stress and anxiety. Do you have worries? Do you worry about what your symptoms mean? Do you worry that they might get worse? Sometimes these aren't unrealistic worries, actually,
Right.
right? But they might be unhelpful, or they might be maybe a little bit in the catastrophic nature, right? There might be some work we can do to soften those.
Mhm.
Other two things are hypervigilance, so symptom hypervigilance, where people's brains are scanning, scanning, scanning. Again, that comes from a good place. It's
Right.
adaptive, right? It's your brain trying to
Protective. Yeah.
it's absolutely protective.
Mhm.
But at a certain point, that can then become like a primary mode,
Yeah.
and that can cause more harm. And then hypersensitivity, and when I work with that, I'm calling it visceral hypersensitivity, right? So it's like it's really, we kind of think about that. I talk to my patients that it's kind of like a nerve issue.
Mhm.
Your nerves are firing way too much. So
Mhm.
things in your body, experiences that you might have that might be totally normal and benign, and to some other person might not experience it as painful. To a person with IBS or a person with chronic pelvic pain, that same experience is painful, right?
Yeah, I
Um,
look at it as like tell people the window of tolerance. Like before all this
yes,
started, your window of tolerance, like your wiggle room, lots of wiggle room before things just
yes,
started, the alarm bells started going off. Right now, after all of this and your journey and the struggles and everything evolving, the wiggle room is like the window of tolerance is tiny. So
I love that.
anything can literally like set the alarm bells going off, but that doesn't necessarily mean that it's dangerous or
Dangerous.
harmful
Yep.
or that you're regressing. It's really that sensitivity dial just ramped up, you
Yep.
know.
And that education alone right there is an example of how we can use something like cognitive restructuring, like changing
Mm,
somebody's thoughts, right? So it's still validating that person's experience, that this is it's painful, it's real. We can even call it serious. These are things that can absolutely worsen a person's quality of
100%.
life,
Yeah.
right? But the dangerousness piece, if we can educate a patient to realize that no, this is an over firing and then an over paying attention that
Mm.
has really kind of screwed up at what is otherwise a normal kind of interaction,
Mm-hmm.
at least it helps a person understand that they don't need to be then afraid about what their symptoms mean. Therefore, boom, if we can get there, we have interrupted that stress response,
Yes, and you can
right?
get back to life. I think the most
Yes.
important thing that I'm hearing from our conversation right now is that a lot of our well, I guess I'm speaking for my patients, and I'm only
Mhm.
assuming that that's what's
I
going
think
on
we
for
know that. Yes, I think that there's a lot to share. We just,
there's
yeah.
right where it's like, what have you stopped in your life? What have you put on hold because of the fear, because of the anticipation,
Mhm.
because of the symptoms? And yes, they are unpleasant and they feel terrible, but doesn't necessarily mean that they're bad. It and we don't need to like put life on hold
Mhm.
when this is over, then only,
Yep.
right? and
Yep.
and our work, and that's what I'm gathering, is that we're giving that power back to the individual to say, hey, listen, I know you're struggling, and life is very narrow right now, and
Mhm.
it's myopic at this moment, and it
Yep.
seems like it's impossible to get back to doing the things you love, but
Mhm.
here's a little, like, here, let's do a little tool, let's do a little strategy, let's kind of
Mhm.
soften, as you said, Elise,
Yep.
soften these thoughts and the worries around
Mhm.
your GI symptoms or your pelvic pain or what have you. You know,
Mhm.
how can we soften and kind of ease into these experiences and also put back a sense of self? Like, who are you now? And can we put
Exactly.
you back into the equation?
And I
Right?
think about that as like a values conversation, right? And
Mm-hmm.
then it's kind of like, how do we how do we start taking the power back from these symptoms? Because
Mm.
the more we sort of allow our life to get smaller and smaller and smaller, the more I talk, like the more powerful they get, right?
Yeah.
And so
Yeah.
at a certain point, it becomes a little bit more about start kind of like starving that monster, and that's hard, right? It means
Yeah.
that at times you're accepting suffering, you're accepting physical suffering,
Mm-hmm.
but doing it with this kind of long game in mind, that part of getting back engaged with things that you love to do helps to starve that monster, right?
Right.
Because then the isolation, the depression, the loneliness,
Mm-hmm.
those that feeds it, right?
That's right.
And again, even just the attention turning it towards those symptoms kind of feeds the monster. So different, different presentations. Some folks need more of one thing versus the
Mm-hmm.
other. But these are the kinds of things we pick up a little bit of it in the evaluation, and then
Mm-hmm.
in those sessions, a lot of it's tracking. It's kind of really exploring what's happening when you're experiencing symptoms, so that we can tailor the approach so that it really can target the things that are relevant for that particular person.
I love it. And it definitely sounds reflective and interoceptive, like having that person
Mhm.
really be able to take themselves out of their own situation and be an
Mhm.
observer almost to
Mhm.
see what is hooking them in,
Mhm.
what behaviors and actions are a result of those triggers when they get activated, and then recognizing, well, is it what I'm doing to help mitigate that or modulate that? Is it really helping me to move forward or move
Yep.
towards something that's more important in my life?
Yeah.
Or is it really kind of hindering me
Mhm.
and really making life smaller and smaller and smaller? And
Yep.
that's what I'm gathering with the beautiful work that you're doing with your
Thank you.
clients, with your patients, of recognizing that and putting hope back on the table and a sense of agency and independence
Mhm.
and empowerment.
Yeah. Yeah, there definitely our sessions are oftentimes they're interactive, they're engaging. Sometimes it feels like we're doing little like
Yeah.
science experiments as we look
I
over our
love
data
it.
together, and trying to it's we oftentimes have a lot of fun. Like, it can give a little bit of, kind of power and control back to a person,
Yes.
and when people have been suffering with these symptoms for so long, it can feel very much like you have little control,
Yeah.
or sometimes you're controlling the wrong things,
Mm-hmm.
and so sometimes I think just having, and I think that that's what therapists, whether it's a physical therapist or it's a mental health therapist or it's a GI, whatever it is, I mean, sometimes just having a partner, having somebody that's kind of like on your team and
Mm-hmm.
is taking that time with you, that you can have that outside perspective. I mean, I very much sometimes just see myself as that person's coach. I mean,
Yeah,
I have
same.
these skills, right? And I can teach them to you, but a lot of times too, I'm here to like cheer you on. I want you to learn this stuff for
Mm-hmm.
yourself.
Right.
And again, that's part of just respecting that each person comes in with their own particular experiences. And so the same thing that may be really problematic for one person is honestly not necessarily that problematic for the next person.
Right.
Right. So I think really taking that individualized approach, and I think having that really good relationship with your patients is helpful. So very lucky. I love what I do, like the day in and day out, and I think my patients usually know that. I have to like
It
sometimes,
totally, I can
right?
see it. I can see it. You light up when you're talking about
Oh
it
yeah,
and you love it. You're so
yeah,
passionate. And that's why I resonated with your energy in the program with the University of Michigan. I'm like,
yeah,
I need to have her on the show because she's totally awesome. And
yeah.
the work that she's doing is awesome. And she's
Thank
transforming
you,
people's lives. So
thank
that
you,
totally, I mean, your passion and energy for what you do, much respect, honestly.
thank you.
And before, and I'm cognizant of time. There was one thing that you had mentioned about gut hypnotherapy or gut
Yeah,
directed hypnotherapy.
yep,
If you can talk just briefly about like
yeah.
the experience of that, because I know hypnosis, there's some good research around it for chronic pain. And so
Yes.
I think there's a lot of overlap.
Yeah, absolutely. I think there's just a ton of unfortunate misconceptions about
Mm-hmm.
hypnosis, and so a lot of what I have to do when I tell patients about this is corrective, and other colleagues too. I think folks in health psychology and other types of fields, like oftentimes are a little more familiar that it has therapeutic benefit, but sometimes it doesn't extend out of that in terms of knowledge. But yeah, it's a lot. I would say, like in practice, it looks a lot like doing a guided meditation, which is something I also do a lot of with patients, but it's kind of getting patients in, a trance state, which I define and others define as a state where you're very highly relaxed while also highly attentive. And this is something that you can get into on your own through yoga, through exercise, through prayer, through other types of meditation, right? But we are doing it in a clinical setting because it can help a person be more creative. They can imagine things more easily. And these kind of normal everyday defenses or strong held beliefs that they have are like a little bit lower, a little bit more receptive in that state. And then what really takes it from more of a meditation to a hypnotherapy session is that we're actually giving suggestions. So we're saying things about your specific symptoms that we want to see changes with. So usually about symptom reduction, right?
Mm-hmm.
And so we, this is actually, these have been, these are considered evidence-based treatments.
Mm-hmm.
They have been well researched in GI and other types of conditions.
Mm-hmm.
And they can be very effective in reducing pain, especially as you said. But especially when we're thinking about someone who maybe hypersensitivity seems to be a key piece of that. It seems that, and we don't understand exactly how it works, but it seems that that brain-gut relationship, that kind of dysregulation of the brain-gut axis, we're able to kind of better train people to have a little bit more lightness in the way that they're thinking about their GI tract. And it seems to also help their GI tract to not respond quite as extremely to sensations that they're perceiving internally or
Awesome.
stress that they're experiencing externally. So it's another component of the work that I do. And for patients with hypersensitivity, where we seem to think that that's playing a pretty big role, then that's
Mm-hmm.
oftentimes a really integral part of the treatment approach we'll use.
That's fascinating. I love it. I love it. What's one of your favorite resources that you like to give your patients? Like if you have to pick one thing to share with the
Oh,
audience, I know you
uh,
probably have a million. I'm sorry to put you on the
no, it's
spot.
okay. I'm going to reach up to my bookshelf. At least I think it's a great starting place, and it's a really interesting read, The Mind Gut Connection by
Oh
Emeran
yeah.
Mayer. Really, really great one. All kinds of really great research in there, but it's meant for anyone to read.
Nice.
So I would say it's just a really nice introduction, and not only, I mean, it really emphasizes the relationship between the brain and the gut, but I think
Mm-hmm.
it kind of can extend to just the mind body period, right?
Yes.
And so really having a better understanding of some of the science that is is behind this kind of work that we do, and integrated care and rationale for the biopsychosocial model. So people love this book. I love it.
Yay.
So
Thank you so much. Thank you so much.
absolutely.
And so if listeners wanted to connect with you, Elise, where can they connect with you?
They can find me on Twitter at Dr. Elise Bedell. I'm always happy to receive an email with questions. You can email me at abedell1@uchicago.edu. And I'd love to hear from folks. And hey, if you're interested in pursuing a career in psychogastroenterology,
Heck yeah.
get in touch. Let's talk about pathways to get you there.
Woohoo! Thank you so much. Thank you again, Elise.
Thank you so much for having me.
Oh, it was a fabulous conversation. I appreciate your time, and really you're a gift to the world. So thank you again for being on the show.
Thank you, Susie.
And to all of our listeners and viewers there, thank you so much for your support and your patronage. And as always, in loving wellness for your pelvis. Until next time, my friends.
Thanks for listening to today's episode. Be sure to head on over to drsuzyg.com where you can get more information, show notes, and related articles on today's topic. Also, if you like what you're hearing, head on over to iTunes, subscribe to the podcast, and leave us a rating and review. We'd love to hear feedback. Thanks again.